Welcome everyone. Today we're going to dive into one of the most fundamental concepts in all of pathology, straight from the pages of Robbins, cellular adaptations. These are the incredible ways our cells respond to all the stresses life throws at them, a process that sits right at the heart of both health and disease. So let's start with the big question. When a cell gets hit with stress, whether it's mechanical force, a blast of hormones, or some nasty chemical, what does it actually do? Does it dig in its heels and fight, or does it change its strategy to survive? This is really the central drama we're going to explore. To get a handle on this, you have to see the whole spectrum of how a cell can respond. You see, a cell normally just chills in a state of homeostasis, everything's balanced. When stress comes along, its first move, to adapt. Now, if that stress is too severe or lasts too long, the cell gets injured, which might be reversible. But if you push it too far, you end up with irreversible injury and, ultimately, cell death. Our focus today is on that critical first response, adaptation. So here's our game plan. We're going to do a quick overview, then we'll hit the 4 major types of adaptation one by one: hypertrophy, hyperplasia, atrophy, and metaplasia. And then we'll wrap it all up with a super high-yield summary. You know, the stuff you really need to nail for your exams. First up, hypertrophy. So what is it? It's simply an increase in the size of individual cells. And when the cells get bigger, the whole organ gets bigger. The key takeaway here is think bigger, not more. Okay, and this right here, this is an absolutely crucial distinction, and I guarantee you'll see this on an exam. Hypertrophy is all about cell size, and it happens in tissues where cells can't really divide, like your heart muscle and skeletal muscle. Hyperplasia, on the other hand, is about increasing the cell number, and that can only happen in tissues where cells are capable of replicating. Size versus number. Got it? That's the whole game. So how does a cell actually get bigger? Well, it's kicked off by a couple of main triggers. Mechanical triggers, like the stretch on heart muscle cells pumping against high blood pressure, and soluble mediators, like growth factors and hormones. The cell responds by firing up its protein-making machinery, churning out more structural proteins. And what's really fascinating is that the cell can even switch back to producing more efficient fetal versions of these proteins to handle the extra workload. All right, check out these images because they show the 2 faces of hypertrophy perfectly. So on the left, you're looking at a cross-section of a heart. And wow, look at that massively thickened left ventricle. That is a classic sign of pathologic hypertrophy caused by chronic high blood pressure. Then on the right, you've got a gravid uterus during pregnancy. This is just a beautiful example of a physiologic adaptation where smooth muscle cells get bigger and more numerous thanks to hormones. So one is a response to a disease state, the other, a totally normal, healthy process. All right, let's switch gears and talk about our next adaptation, hyperplasia. And like we just drilled down, this isn't about getting bigger, it's about getting more numerous. Here we're talking about an increase in the total number of cells, all driven by cell proliferation. And just like we saw with hypertrophy, you can really split hyperplasia into 2 main categories. You've got physiologic hyperplasia, which is a totally normal response to some stimulus, and then you have pathologic hyperplasia, which is caused by some kind of excessive or inappropriate stimulation, usually from hormones or growth factors gone wild. Let's run through some classic examples you'll definitely encounter. For a physiologic hormonal response, think about the glandular tissue in the female breast multiplying at puberty. For a compensatory one, you can't beat the liver's incredible ability to grow back after a piece of it is removed. And for pathologic examples, endometrial hyperplasia from too much estrogen is a big one, as is the super common benign prostatic hyperplasia, or BPH. Okay, now listen up, because this is probably the single most critical clinical point you need to know about hyperplasia. You've got to remember this line from Robbins. So, what does that actually mean? Why is it a fertile soil? It's because all that stimulation that's driving the overgrowth, it's also cranking up cell division. And when you have more cells dividing more often, what happens? Well, it's just a numbers game, really. You have a higher chance that a mutation's going to pop up and push one of those cells towards cancer. All right, we've talked about getting bigger and more numerous. Now let's flip the script and talk about atrophy. This is when an organ or tissue shrinks, and it's a 1-2 punch. Individual cells actually shrink in size, and you lose some cells altogether, reducing the total cell number. And wow, this image really paints a stark picture of what atrophy looks like. Just look at the difference. On the bottom, you have a healthy brain. On top, the atrophic one. You can literally see how the gyri, those are the folds, have gotten super narrow, and the sulci, the grooves in between, are way wider. That's the direct result of losing brain cells. So what's going on inside these cells? How does this happen? Well, the cell is basically kicking into survival mode. First, it hits the brakes on making new proteins to save energy. At the same time, it starts breaking down existing proteins like crazy, mainly using this thing called the ubiquitin proteasome pathway to tag them for destruction. And on top of that, it kicks off autophagy, literally self-eating, where it recycles its own parts for fuel. It's a strategic retreat to survive. And when you actually look at these atrophic cells under a scope, this is what you often see. This is called brown atrophy of the heart. You see those little brown specks inside the cells? That's lipofuscin pigment. We call it the wear and tear pigment. It's basically just the leftover junk, the undigested bits from all that autophagy. It's a dead giveaway that a cell has been through some serious atrophy. Okay, our final adaptation. And this one is probably the most fascinating of them all. Metaplasia. We're not talking size or number anymore. We're talking about a complete change in identity. It's a reversible change where one mature cell type gets replaced by another one that's tougher and better able to handle stress. Now, the mechanism here is absolutely key to understand. It's not like a mature, differentiated cell just magically morphs into another one. That's not how it works. What's actually happening is that the chronic stress is reprogramming the local stem cells in that tissue. These stem cells are then told to grow up and differentiate along a totally new path, producing a different type of cell. And the classic textbook example of this, look no further than the airway of a chronic smoker. Normally, you have this delicate, ciliated, columnar epithelium that's great at clearing mucus. It can't stand up to the constant assault of cigarette smoke. So through metaplasia, it gets replaced by a much tougher, more rugged, stratified squamous epithelium. The new cells are better at surviving the smoke, for sure, but here's the catch. You lose that all-important protective mucus-clearing function. And here we go again. Just like pathologic hyperplasia, metaplasia comes with a huge warning label. This quote from Robbins really drives it home. The idea is that the same chronic irritation that's forcing the cells to change, well, that stress can also cause mutations. Over time, this can lead to dysplasia and eventually full-blown cancer. The perfect example is Barrett esophagus from chronic acid reflux. That metaplastic tissue has a much, much higher risk of turning into esophageal cancer. All right, let's pull all this together. This summary table is pure gold for studying, so pay close attention. For hypertrophy, remember, bigger cell size, more protein synthesis, like in the heart. Hyperplasia, more cells, driven by growth factors, think BPH. Atrophy, smaller cells and fewer cells, thanks to proteasomes and autophagy, like a muscle you don't use. And finally, metaplasia, a total change in cell type because of stem cell reprogramming like in Barrett's esophagus. Okay, here are the absolute must-know high-yield pearls for your exams. If you remember nothing else, remember this. First, hypertrophy versus hyperplasia. It all comes down to one question. Can the cells divide? Simple as that. Second, for atrophy, the two phrases you need burned into your brain are ubiquitin proteasome pathway and autophagy. And finally, the big flashing red light. Both metaplasia and pathologic hyperplasia are dangerous. They're that fertile soil where cancer can grow. Lock those in and you'll be in great shape. And that really brings us to the big overarching question, doesn't it? You know, these cellular adaptations, they're truly brilliant survival tactics. But they're always walking a tightrope. The line between a helpful adaptation that keeps a cell alive and a harmful disease that can ultimately kill the patient is razor thin. And understanding that boundary, well, that's at the very heart of pathology.